we do is, the first question you ask is, are we accessing the venous system or the arterial system? Okay, it's really important. So it's either arteries or veins. You have to figure that out first. And then usually in vascular surgery, it's either you're bleeding or you're clotting. Okay, very simple. Veins or arteries, bleeding or clotting. Okay, so a lot of the procedures we do is for clotting problem, and one of the common things that we're doing more and more of it, and in the past we used not to really have the tools to do it, but people coming in with DVTs. So the treatment for DVTs is really still blood thinners. Okay, 90% of the time that's all you need is blood thinner. But for people who have severe swelling of the leg, and that usually means because they have not just DVT in the leg, but it extends up to the iliac vein. So the iliac vein is bigger. So what we call iliofemoral DVT. So for those patients, the swelling can be quite severe. So for those patients, we offer them the option of us going inside the vein to suck out the clot, to debulk it, and get the swelling to come down more quickly. Do they have to have it? No. For years, we didn't have that treatment, but now we have that treatment, so we offer it to patients, but only if they have severe swelling. So when we do a DVT thrombectomy, we have to use fairly big devices, okay? And so the access sites, they come in all sizes, and you guys know. So this is the smallest access device we have. This is a 5 French or 4 French. You're familiar with the French system, right? Just like the Foley catheter, right? So what's the French of the Foley catheter? 16, right? So it's the same thing. So this is a 5 French, okay? And so we usually start with this. We get into the vein or the artery with the smallest one, make sure we're in the right spot, and then we upsize it. And so usually we upsize to a 6 French in the artery if we're doing something. So this is like a 6 French, okay? This is a typical French that we use for arteriograms. This is a typical French that they use for coronary angiogram, okay? By the way, here's a quiz for you. If you had to sort of guess, which vessel would be bigger? So the femoral artery or the femoral vein in the groin? Which vessel is bigger?
I say the artery.
Yeah. Yeah, so you think artery is important, right? But artery is actually smaller, okay? Artery is smaller. So any parts of your body, the deep veins are always bigger than the artery. Okay, so you don't want to put a big sheet in the artery if you can avoid it. Why? Because the artery tends to be smaller, and also if you put a big sheet in the artery, you may be blocking the blood flow to that sheet. Okay, so veins are much bigger than arteries. So the type of clots that we remove out of the veins, huge amount of clots, huge amount. The arteries are much smaller. So you're talking typically like a femoral artery would be 6-7 millimeters. A femoral vein would be almost double that size. Okay, so veins are always bigger. And because they're bigger, when they fill up with clots, there's a lot of clots. Okay, so 6 French, this is 5 French. So for a typical venous thrombectomy, we would actually use a 16 French. I didn't really have a 16 French, but yeah. Okay, so this is a 20 French. So 16 French is a little bit like the Foley catheter, right? So this is a 20 French. So we actually use a 24 French for some of the thrombectomy that we do. So along the side of venous thrombectomy, you know, so people get a PE because they have clots travel to the lungs from the venous system, right? So PE thrombectomy is the other thing that we do in these patients as well, right? If they have embolized their lung. And so again, the treatment for PE is just like DVT. We don't have to do any of those because the main treatment is blood thinners. And even if we go in there to remove the blood clots out, we make sure to tell them, even if we go in there to try and debulk the clot out, you're still gonna need to be on blood thinner because we're not able to remove all of the clots, okay? So that's really important for patients to understand. Whether we do the procedure or not, they're still gonna need to be on blood thinner, still gonna need to be on it for 3 to 6 months, okay? So a PE thrombectomy, we actually go from the groin all the way up to the pulmonary artery and suck out the clot. So there's several different devices that we use, but so typically we have to actually put a big sheet. Okay, I'm gonna pass this around so you can see. This is a big sheet. This is a 20 French. Okay, that's a 6 French. Okay,
Yeah.
that's massive.
So when you say blood thinners, you're talking about heparin?
Heparin. And then they go home on, you know,
The Lovenox?
Xarelto or Lovenox or Eliquis. So these, they all come in, so these sheets, so you know, they actually all have what we call a dilator, okay, that goes inside. And the reason for that is because this is a blunted thing. You don't want to push this in the artery or the vein like that. You need something more smooth.
I'm so sorry.
No problem.
Shoulder coming, okay? They will take time.
So this is sort of taper, so you're not going to damage the blood vessel. So we always have a wire, and we push this over the wire. The wire guides you.
Okay, and then you just slide that. This goes into the patient.
And then you take this out.
This part goes in the patient. Okay.
Right. And then you just shove other stuff.
Mhm.
So through this sheet, we would then shove a little catheter that will go inside the blood vessel to suck blood clot out.
Oh.
This is the working sheet.
Okay.
So you go in like this, and you leave this like this.
Wow.
And then this is going to go to another catheter is going to be passed inside of this to go in and suck. Okay.
It's just convoluted.
Mm-hmm. And then when we do a thrombectomy, usually we come from the legs. So this would be like this. And then through this catheter, we shove a different kind of thrombectomy catheter to do what we need to do. Okay. So you can pass it around if you don't feel it. It's quite big. So I was just going to show you this one video here just for fun. So this is a patient actually that came in with PE on both sides, and he was quite short of breath. And on the CT, we showed that he had clots in both his pulmonary arteries as well as in his right atrium. It's quite a big clot. And here, I'm not sure you can see it from there, but this is that sheet here. I'm actually pulling this out. So usually what we do is we leave the sheet inside the patient, and then we go up and then we pull the clot through another catheter, okay? But this clot was too big. It wouldn't come through the catheter. It was because it was too big. So we actually had to pull the whole sheet out. And you'll see, that's the clot at the end. It's a big clot. We actually had to pull the sheet out because he's going to show you a bigger. That's the clot there. Okay. So that clot was sitting inside the right atrium. Okay. But you see that big sheet there. So most of the clots you can just break it up and suck it out through the sheet, but this one it wouldn't come. So we actually have to pull the whole sheet out while grabbing onto it. Okay. How do we move to the next slide? Where's my?
Randy, do you know how to skip the slides?
There we go. Anyways, this is a closet we took out from his lungs.
Wow.
Okay, and this is a typical. That's the ruler, just to tell you. That's like 10-centimeter ruler. And these are clots that we took out from a patient a few days ago from her iliofemoral DVT. So this is the venous clots. They're huge. They're big. Okay. The arteries are a lot smaller. Okay. So the importance of when I told you about artery and vein. So you need to know what kind of procedure we did. Was it in the vein or was it in the artery? Okay. And typically, when you pull out a big sheet from the vein, not a problem. You just put pressure on it. Because the venous pressure is very low. Okay. You put pressure on it, it's going to stop bleeding. It's very unlikely to have a hematoma develop after venous procedure. Okay. If you access the vein, low pressure system, you pull a big sheet out, not a problem. Okay. So that's important to know. So, and typically, popliteal DVT, we put the sheet behind the knee. For PE, we usually put the sheet here in the groin. And when you pull the sheet out, because it's a vein, put pressure on it. Usually we have a stitch kind of close to skin. Okay. So that's the veins. Let's talk a little bit about the arteries. I know we're running out of time, but so arteries, what do we go inside artery to do, you know? So coronary angiogram, coronary stenting, we go through the artery, right? Now some people now are going more and more through the radial artery. Why do we go radial rather than femoral? because when you pull the sheet out here, those sheets are small, and you just put pressure on here. It's easy to put pressure on, right?
Bleed and clot.
Less bleeding, less, more patient comfort, you're not like in the groin and stuff like that. So it makes sense, okay? And there's less problems. So here, if you clot up the radial artery because you press too hard or something, usually patients are asymptomatic because the ulnar artery is the more important one. So you don't really know about it, okay? So we're doing more and more stuff from the radial artery for coronary angiogram. But for us to do the leg intervention that we do, we ain't gonna be able to use the radial artery. It's too far away. We have a catheter that goes all the way down here.
Yeah.
So at the moment, the technology is not there. So what we do in the leg, when we do leg intervention, so people with PAD, peripheral artery disease, they have blockage. So we go into the artery to open up the blockage by ballooning it up or by putting a stent in. So typically we go from one side to treat the other side. Why is that? Why can't you just go like this? Because the technology is not there. The catheter are made. You need a good segment to be able to push things through. So that's why we go from one side to treat the other side. That's just because of the availability of the different catheters that we have. To puncture right here, to treat down here is hard. Okay, so that's why we don't do it. So that's really important to remember. The leg that we're treating is usually on the other side. Okay, but the difference between artery and vein again. So we usually, when we puncture the artery, it's important for you to know which leg is the bad leg, right? But certainly you can cause complication on the good leg, right? Why? Well, you can bleed from that side or you can clot off that side, right? So it's important to check the pulses in both feet. It's important to know what the patient had before surgery, before they did an intervention, compared to what they have post-surgery, right? So, but you have to check on both legs, right? So the leg that was treated and the leg that has the sheet in, right? So usually for treatment in the leg, we use sheets that are about 8 Frenches, something like this, okay? Smaller, okay? Arteries are small, right? And the kind of stent that we put in are stents like this. Okay, I'm going to show you the difference. There's 2 types of stent. There's soft stent and there's hard stent. And you can pass. This is really soft and this is hard.
Oh, wow.
The hard one is the ones that they put in the heart. Okay.
This one?
The hard one, it has to be hard, and those are the ones that are put in the heart. They're balloon expandable, whereas the other one is self-expandable. But anyways, those are meant to be in the artery. So hard and soft. Not that you really would know the difference, but just in But so those stents are collapsed, right? And then they go through the smaller sheet. They go through the coronary stent actually go through a 6 French sheet. So they come collapsed and then you kind of open it up inside the body. Okay, but the sheets are small. But even with small sheet, you can still bleed on the arterial system, right?
High pressure.
Because it's a high pressure. Now you may ask, so why is it some people need 1 hour bed rest, some people need 2 hour bed rest, some people need 6 hour bed rest? Why?
Well, it depends on, they have a closure device for one, usually that makes a difference.
Exactly.
And then, some people tend to bleed, depending on their coags and stuff like that.
Stuff like that. But in the old days, when we didn't have closure device, right? We put everybody at bed rest for like 6 hours or
Oh,
something.
yes.
And then we would have these like very cruel C-clamp on people. Right?
Yes.
It's cruel. I find it very cruel. But we don't use that anymore, but so we have these closure devices. And what are the closure devices? So the closure device comes in a device just like similar to this system, and then we go in and then we deploy sutures from inside. And so in effect, the sutures are tied down and then we cut it. So there's a small incision, but the suture is inside. So because we close that hole with sutures, they really are, closed. They don't really need to be bed rest that long. There's multiple different closure devices. There's some closure devices that have an arterial plug. Some is like you leave a plug on top of that hole. Some is a suture, so it kind of depends. And depending on the closure device, the company recommends, 1 hour, 2 hours, or no bed rest. And then a lot of it depends on the physician preference as well.
Yeah.
So for me, when I use my ProGlide suture device, I usually say 2 hours. But the company said they can actually just walk out of here, Yes. But I have tended to just be a little bit more on conservative side. So that's sort of a little bit physician preference. Okay. So it's important to know, did they poke the artery? Did they poke the vein? If they poke the artery, then we need to know. It would be nice for you guys to know what size sheet did they have, okay? Because if I tell you I have this size sheet in the artery, you're gonna be a little bit more careful, right? Versus this one.
Right.
So the incidence of bleeding is a lot higher with this. The incidence of pseudoaneurysm formation is a lot higher with this, right? So you need to, it'd be nice for you to know, is it small size sheet or big size sheet when it's in the artery, okay? And then whether we use a closure device or not, okay? So that's why the variability between the amount of bed rest kind of depends on the physician's preference a little bit. So sometimes we do put this in the artery, right? Why? Why do we need this? Well, the stents that I show you is pretty small.
Because?
To remove clots.
Yeah.
No, the arteries clots are small because the artery vessels are small. So you need this when you're gonna put something like
Like
this.
a balloon?
No, like this. You can
Is that
pass this
balloon?
around. So these are the EVARs. These are the people that get aneurysm, and we put these in. Okay. You may not get those
But I
here as
did
much.
too.
What's that?
Aneurysm too.
Not these aneurysm. These aneurysm
these
here.
aneurysm.
These abdominal aneurysm. Okay. So the
Oh.
abdominal aneurysm is like, so the
big,
aorta
you
is
see the
bigger.
size is bigger.
Yeah, don't get
it's
it.
not
So
the same
this is bigger. So
Oh.
these
These
people
are
with
big.
aneurysm here, we put these stents in here to fix the aneurysm. So they come, because they're bigger, they're loaded on bigger device. So we need to see bigger sheets. Okay. So that's why this is actually a typical sheet we use for putting these around. But so this is the typical stent that we put in for people with abdominal aortic aneurysm. Okay. And usually when we do this in the artery, we put a lot of stitches to close that hole.
Okay. And this is permanent?
That's permanent.
This-
It ain't coming out. All
okay.
stents are permanent. There's no way you can remove any stents.
Okay.
Once you put the stent in, it's in for life. The only way to remove stents is actually cutting on them. Like you actually have surgery to remove it. But a lot of times when the stent becomes occluded, you just forget about it and just leave it.
Oh.
Okay. Now one last thing I want to show you in case you haven't had a chance to see it. So these are the filters. So this is the only thing that we can remove. So these are not stents, these are IVC filters. Okay. So they have a little hook at the end there. So what we do is we kind of hook it up. So when we put it in, so usually these filters, we remove them after they don't need it anymore, like 2 to 6 months. And then we collapse it down, and then we pull it out. So these are the only metals in your body that you can remove without having to have surgery.
IVC, what is that?
Oh, you can do that.
Inferior vena cava.
Oh,
yeah,
yeah, sorry.
yeah,
It's,
yeah.
it's early.
Inferior vena cava. Careful, yeah, there's the hooks. The hooks are important because we don't want them to travel in your vein.
Oh, so
Yeah,
they,
it's not
they
go-
keep it from moving.
Yeah,
Okay.
just stuck.
It's like a decoration.
It's like a what?
Decoration.
It's very expensive decoration.
Christmas decoration.
And where's this located at
This
usually?
is the filter, so
where do
it's,
they-
it's meant to be.
Mhm.
So people who have a
The
blood
one on
clot.
the teams, they don't see it, but it's
No.
like, oh, how would you say that?
It's
How
an
would you
umbrella.
describe? Yeah, umbrella, like an umbrella. Yeah.
Yes. So
Yeah.
this is the IVC filter
Mhm.
is meant. It's indicated for people who cannot be anticoagulated. So a patient come in with a DVT and they have GI bleeding, so you cannot put them on blood thinners.
Okay.
So you put this in to prevent clots from traveling to your lungs.
Oh, okay.
So is
So
it
it's
like,
right here.
is
Oh,
it
it
gonna
goes right
come with
there.
a mesh or something, or it gonna filter everything?
So it filters the bigger one, so it will
The
stop
bigger
there.
one,
Yeah.
okay.
Oh.
But you're right, it's a good point. You can still have
The small
smaller
one.
clots
Me
traveling.
is there,
Wow.
yeah, the escape from there.
That's very interesting.
Yeah.
There's no mesh, this is the
But a
filter.
big one not there.
But it's supposed to filter
The big one.
the big one.
The big one, yeah.
I got a picture.
Yep.
Interesting, huh?
All right, any questions?
And then that's